Whether we're attempting to identify an infectious disease outbreak or we're trying to characterize infection epidemiology, information is needed. There are many ways to get information, such as digital medical records or interpersonal communication. We will review the different types of communication involved in gathering information and define some key concepts: surveillance and disclosure. Let's start by defining surveillance. Surveillance refers to watching over someone or something and recording those observations. This seems relatively simple, right? If we just watch hosts and their pathogens carefully enough, then we could rapidly detect an existing, new, or reintroduced pathogen. We could identify times when pathogens are most amenable to elimination. We could predict changes in infection incidence and prevalence based on changes in either the hosts or the pathogen. We could detect resistance early and adapt our control strategies accordingly. Fundamentally, surveillance depends on communication. One important form of communication is disclosure. People must come into a medical office and disclose their symptoms and concerns. Their medical personnel may then disclose their professional diagnoses, their patients' test results, and potentially physical samples to health agencies. Health agencies then disclose concerns about an infectious disease outbreak to the public, so those with symptoms seek treatment. And the cycle continues. There are two tasks in these disclosures: speaking and listening. Both tasks are challenging for different reasons. Typically, people wait until they experience disease symptoms to interact with the medical community. This delay means that infectious agents have already gotten a foothold within the community. In addition, symptoms vary in their visibility and measurability. For visibility, sores on arms are visible, while pain is not. For measurability, thermometers can detect a fever, but it can be hard to measure how much something itches or how disoriented you might be. Patients need to be taught how to express themselves and their experiences to medical personnel, especially for invisible, unmeasurable symptoms. Those listening to patients also need to be trained in how to listen and interpret what patients say. In many countries, such training is a part of medical school, but this training varies depending on one's role, such as a nurse or doctor. Without listening carefully, providers can miss important information from their patients. Sometimes, caregivers are the ones speaking to health professionals on the behalf of someone else, such as parents for infants. In these cases, caregivers engage in both decoding the verbal or nonverbal communication from the infant and then expressing their thoughts to the health professional. These translations can be very difficult to do well. There are two ways to facilitate the accuracy of disclosures. One way is to educate people on how to express their ideas in ways that better represent what they are experiencing, such as their symptoms, or what happened. Who did they see last? What did they eat, etc. A second way is to train health professionals to listen carefully to what someone is telling them. With training, there is ample evidence that surveillance can be improved by helping those experiencing symptoms to express themselves more clearly, and for those listening to decode what they are saying more carefully and accurately. On a larger scale, the lay public can play an active role in surveillance through citizen scientist groups. Indeed, in the United States, citizen scientists have played a large role in the surveillance of birds, which has alerted scientists to new infections and provided them with quality data. Disclosures and monitoring, however, are not enough to ensure careful surveillance. Evaluating what is observed and learning from attempts to intervene both play important roles as well. Monitoring, learning, and evaluation, sometimes referred to as MLE, are complicated in situations when multiple organizations and multiple actors are involved. Some efforts include health agencies, private industry, funding agencies, and nonprofits representing scientists, clinicians, and interventionists. In other words, investing in real-time comprehensive monitoring does not inherently lead to access to data or to coordination among different organizations and actors. Without access to needed information, scientists will be unable to characterize the infection and its dynamics well. Without coordination among organizations, we may see some affected areas getting duplication of services, while other affected areas are missed completely. When data is delayed and coordination is missing, infection control efforts are compromised. To recap, the social sciences of communication and group coordination play an important role in identifying and managing infectious diseases. With current, dynamic, accessible information and trained personnel who can learn from it and act on it collaboratively, we can improve our chances of identifying emerging infections well, allocate resources efficiently, and adjust programs and policies appropriately.